almost 2 years ago.
Okay.
And I'm not really, I should be more consistent with my videos, but I'll get better.
Okay. That's what's up. So what are you, I don't know if that's right. Let's see. We'll see. What's your channel about?
It's mainly about nurses making a transition away from the bedside into medical coding.
Okay.
Or like the HIM industry, just in general.
Okay.
Because most nurses, like when they reach out to me, they have no clue what it is they want to do or how to do it. They just know, I've heard about coding, but that's it. Like they don't know whether they want to work inpatient, outpatient.
So, can you hear me? Okay, let me see. What did I just do? Something's low. You got an echo now? Let me see. What did I do? 5-8 me. FXCN. Return. Okay. Is it still an echo? You just low. Maybe it's here. Okay. Say something.
Hello?
Oh, yeah, I hear you real well now. Okay. I hear you real well.
But now the echo's back. I can hear it.
Oh, it's a double echo. You hear echo in you?
Yeah.
Let's see.
Well, you know what? Maybe it's not that. Maybe it's just me hearing it from your speaker.
So maybe I should turn the speaker down. Okay. And put on headphones. How about that? Look, we gonna learn. We gonna learn. We are going to learn. Okay. Can you hear me now? Do you hear the echo? Okay. Let's see how this works. I'm trying. Every week I'm trying something. I'm trying. Okay. Good. So let's see. You said you had a great, oh, wait. See now, I forgot to do something. Now I'm seeing all kinds of messages come across my phone, and my phone is on the on the live. Hold on. that would be a no show. Never know what you're gonna get. Hold on. Do not disturb is on. Okay. Okay, I think we're back. Yeah. So, you said you had a good interview. Is this doing the same thing? What is this for? Okay. Oh. Okay. 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 Hmm. Hmm. Right. Nope. Right. Right. So, um, wow. Yeah. So the um the you sound like you're setting up their whole CDI department. So are you jotting all this down so you can get your manuals together? Sounds like yes, they do. They do. And you would think, well, you're the manager, it's all about the managers, boss, or there needs to be some management training across the board in some of these areas that they would have those things. Or I don't know, maybe it's just, sometimes the HIM or HI department is kind of siloed, and in most instances they're not. And so you would think, they would take cues or get assistance from other departments that, offer those types of documents or policies or what have you to assist. But I mean, we for years HIM actually for years HIM had been the actual forerunner in that. They would be the ones that folks would come and ask, do you have a policy about this, or can you share about, so I don't know what happened. Well, what happened, sir? Share. Hmm. It's more than that. Mhm. Mm-hmm. Yep. Wow. Correct. Correct. Hmm. Wow. I know. It's just it's weird. And like I said, like I mentioned last week, there's a lot of talk about um outpatient CDI, which is great, but it doesn't seem like inpatient CDI is strong. You know what I'm saying? So you would think you want it doesn't seem like it's strong. Um, and maybe there's just these are just one-off cases. Maybe there are some CDI inpatient CDI programs that are top notch and doing what they do. And so it will be easier for those types of organizations to make the transition into the outpatient CDI world versus um, some of these others that their CDI programs are not as strong and yeah. Hmm. Correct. Yes. Right. Hmm. Yeah. I wonder if there's some I need to reach out and say, well, some of these smaller places. I mean, I know. So think about a smaller organization, outpatient physician, maybe, mm, maybe surgery center, maybe not, but a smaller organization. And in those organizations, usually, it has been my experience that the doctor runs it all. Whatever he or she says is what's supposed to go. And so I'm curious how those types of organizations, because I mean, do they even have a true compliance plan? Do they understand? Right? Do they understand the importance of having those types of structures in play um, that protects not only the organization but it protects the providers and your coders and billers and everybody that's all involved in reimbursement. So so it's going to be curious to see how they will or if they will adapt to an outpatient a CDI type program in their organizations. Because usually it's been like, well, I said this, do this, or and then that trickles down from person to person. Well, he means this or she means that, so this is what you're supposed to do. I don't know what that means. They didn't document that. Oh my god. Hmm. Mm. Okay. Mm. Wow. Mm. Never. And they clearly state that. And even with this whole copy, cut, and paste from these providers, that was one of the reasons why they really harped in on that, because there were several abuses. Let's say that. You're like, oh well, he already said it, so let me just let me just copy this part of his note, put it in my note, and keep it moving. It's like, oh no. Oh no. So let's see. I saw in the news that, of course, all of the uh, organizations that's out here getting money, um, looking for every bit of um, the auditor side of the house. They are tapping into a brand new group of folks. So not only are they looking at and getting, hospital systems, physician offices, smaller organizations, even I think there was something on a managed care organization recently, but now they have went over into the private equity firms. Yes, yes, sir. And there's a private equity firm that now has a $25 million settlement for False Claims Act. Yes, yes. And so, these private equity firms, I remember working with an organization that, they do all of these startups, and then they want to kind of mirror what they're doing and show the growth and show, we're worth purchasing, we're worth buying. And so they get with these private equity firms, and they buy up all the different organizations. And so it's like it's similar to kind of what the hospitals did with the physicians, if you will. They bought up or merged with or employed a lot of the physicians who had their own shops. And so private equity firms kind of do the same thing, where they purchase various healthcare entities. Well, now they and some of them are actually involved in the operations of these firms or these organizations, which increases their exposure to the government and False Claims Act. And so, yeah, there's one that looking at I think it's in a mental health. I believe it's in mental health, which they come in for all things mental health because it's relatively new. I think it's in Massachusetts, and yeah. I want to say false claims. I'm trying to find exactly what they are accused, alleged. Oh, that they routinely employed, and this is to your point about folks billing, routinely employ unlicensed, unqualified, and unsupervised staff at its various mental health entities. Yeah. And then they submitted the Medicaid claims for the services for those staff members. Yeah. Like they coming for everybody. They're taking no prisoners at all. So that was something that was in the news this week. Also, um, the final rules are out, and I'm so happy. I talked about when the proposed rule came out, when the outpatient prospective payment proposed rule came out, and they were talking about physician assistants. Well, it was approved, it was passed, and so it's in the final rule that physician assistants will be able to bill for their services, so they'll be recognized as the billing entity. So that's good news. Hopefully, not independently. Not independently. No. They are, but there's a difference. So NPs have way more weight, if you will, than PAs. And PAs had to lobby because they had to lobby hard to try to get to the level where NPs are. NPs technically still have they don't have the autonomy to actually they still have to be connected or tethered to a physician. So even um in these entities where they're opening up, like even when they're opening up their own shop, there still has to be some sort of physician oversight. Unfortunately, they can bill, but there's still some physician oversight. And so they have been lobbying for years, which I hope this new piece with the PAs will kind of push legislation for the MPs to be able to do their own thing without supervision as well. Mm-hmm. 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 Right. Right. Yep. Wow. Wow. I know I was in, I think went into somebody's, because there's a lot of nursing rooms. I'm sure you're involved in all of them. Oh, really? I thought you would be involved in more. Mhm. So there needs to be some male. There's some male nurses. I love to see male nurses. Oh, well, yeah. Well, then there you go. There's your opportunity to rally and open up a clubhouse uh, group for the male nurses who are also interested in branching out on their own and being entrepreneurs. You may have a whole different segment of people out there. Because I'm always excited to see, male coders, particularly, African American male coders, because I'm like, where have you been? How did you? We've been telling y'all for years to come over here and get this money, and where y'all been? Like, here's an opportunity, and I love when I have them in my class because it's like, really, it's like, oh, and I'm just fascinated. Like, where you been? What, there's one particular gentleman that I taught years ago, and I still see him around. Um, when we well, especially when we were face to face networking with our local AAPC chapter or what have you. But and then I see him around socially as well. And we know a lot of the same people, but it's just I love it. I love seeing, the strides he's made and the opportunities that have been presented to him, just because he was a certified coder. And it's like, this is something real. This is, you don't, I don't know. Some men think they need to either, I don't know. They need to get dirty with their hands or do. It's like, no, you can come into this office, you can come and do some work. My husband is one like, oh, that's tedious. Whatever. Really. True. Yeah. It's a different kind of situation, boy, I tell you. In certain places. And you're right. There's an additional uh, level of learning in understanding organizations and departments that are primarily female run and operated. um, yeah, I've had managers of both genders, and so of female and males, and it's like night and day. It's like night and day. Oh, right. So I wonder why they wouldn't. Why what's what? Hmm. Well, and I think I think men oftentimes think that that's what it is. It's just women's work because it's detail oriented and they don't want to be bothered with that. Some men, they don't know what it is. They don't know what we do. Right. 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 Wow. Right. Exactly. Wow. Wow. Yeah, you're right. It's probably just a marketing thing. Like, how do you? Hmm. Interesting. Interesting. I wonder. I mean, there's an opportunity there to reach out to the gentleman in the world. Right. Right. Hmm. Interesting. Interesting. Well, hmm. And with all of this work from home, like I have been seeing like a lot of coders, newly certified coders, become frustrated with um, seeing the information out there about the demand for coders and all of that, but then not being able to get the positions. And I wonder how with the shift to remote work, the remote workforce, even in the HIM departments, how difficult is it going to even be, for them who haven't had an opportunity to kind of work side by side? I guess in some instances they will maybe force them for some type of training to come in, but you still don't get the full grasp of what it is like to be in a department side by side before going out there and working from home. But they can train online as well, I guess. I mean, mm, Right. Right. You're absolutely right about that. Hmm. We have one of those here. That's it. Yeah. Okay. We have one of those here. Mm, really?
That's really all you are. How can you tell a certified coder how to code?
Wow. That's crazy.
But the thing is, I didn't blame them. I blame the people who gave them the authority.
Yeah.
And that's the kind of foolishness that's going on.
Foolishness. I don't know. It amazes me that with new organizations, like that they don't know these positions, that they don't know what these positions do, the value of these positions to the organization. Um, that just amazes me. They think that, I mean, I know in some instances they are considered production, but there's still a method to even that madness. And it amazes me that people don't take the time to understand those things before embarking on these. It amazes me.
Well, I think some of them don't even have a clear vision. Or I think what happens is the powers that be, they're making money, but they don't realize that they can make even more money.
Ugh. Yeah. Like if you understood what you had right here in the palm of your hand and capitalize on that, you would be great. But you don't take advantage of of what you have, the resources that you have in your human capital. You're not taking advantage of that. I don't understand.
Right? But, but if you have somebody who has no coding knowledge over top of coders, how can you maximize the talent pool that you have?
You can't.
You can't.
You can't. You can't. Hmm. And so again, there's a deficit there. Huh? I'm sorry.
Oh, I said, because they don't know how to get the best out of them.
Right. That's what I'm saying. So you have a deficit there that you don't even have the right people in the right positions.
Exactly. And I've seen that constantly.
then you also have to think, similar to, nurses who burn out or what have you, you oftentimes have coders who are not interested in management. They don't want to go that route. They want to stay in production. They want to stay, they don't want to be responsible for all the things that come with that. Because yeah, it could be a lot. It could be a lot.
The reason why they probably don't want to is because everybody is not built for the fight.
You're correct.
And everybody cannot hold their own.
Correct. Hi, Mars. Welcome to the room. Feel free to come on up to the stage if you would like to chat. I need to also let you know that we are on Zoom as well.
Because I'm telling you, Clarice, when you start into risk adjustment, you'll see.
Right. Hi, Mars. Welcome.
Hi, Clarice. Actually, I'm not a medical coder. I'm wanting to be in one, but I don't have any guidance to go about it.
Okay, so you're just interested in the profession, interested in the field?
Yeah, in the profession.
Cool. Well, welcome. At least it starts with understanding or having the appreciation of what it is that you want to do. So it starts there. Feel free to. I have a link in the Clubhouse where it talks about the 5 steps to become a certified marketable medical coder. It's a little email course that will send you emails to get you all the 5 tools that you need to be successful in certification.
Okay. Thank you so much.
You're welcome.
Be sure to see it. Yes.
Do you have any specific questions that you want answered?
I actually have no clue about this profession, so only when I read about it, I might have questions.
Okay, well, stay in touch. Feel free to hit the little green Clubhouse so you can be notified when we open up our room every Saturday, or network with Jessie or myself. We will be happy to answer any questions that you have. So stay in touch.
Thank you, Clarice.
You're welcome. You too.
Yeah.
Okay, Jessie, I'm sorry.
No, it's all right.
I'm trying to keep, because I'll miss people. They'll pop in and I'll miss them, and I try to at least acknowledge folks when they come in the room.
Right.
I got too many rooms open right now.
Did you take the headphones off? Because I'm starting to hear the echo again.
I did, because for some reason they're not hearing it in the room.
In the Zoom. Oh, okay.
I don't know what I did, and I don't have my rig. I'm gonna have to, for real, just one day take and troubleshoot and do this supposedly the right way versus trying to put all this stuff together 30 minutes before the Clubhouse. I'm gonna sit down and do it on a Friday. Like, okay, put this together and write it down in my. I keep my Clubhouse book, so write it down in my Clubhouse book, step by step. This is what you need.
Right.
I'm sorry you're hearing the echo.
My bad.
Yeah, so I think there's a lot of opportunities out here. I think it's a way to connect people, and then people have to know truly for themselves what is it they want to do. I mean, so I think it's twofold. One, there needs to be more information about the profession, what we do, what options are available, and then two, individuals need to understand after they get that information, what interests them. What do they, where do they want to play?
Right.
Because there's a lot of.
Go ahead.
Go ahead.
I just did a video I posted on YouTube a couple days ago, and it was titled "The Shift," and I was talking about. I was talking to them about all the changes in healthcare and particular nursing and how it's not going to change anytime soon, and how a lot of people are starting to leave the profession and rather than leave, just learn a skill where you use your clinical skills in a different way. And I was just telling my, the number one question that most nurses ask me when they want to inquire about coding is they want to talk about, what am I going to have to take a pay cut? And I told them, I said, first of all, like the average registered nurse in the United States makes between $60,000 and $75,000 a year.
Mm-hmm.
So that's not ballroom. Now in California and on the coast, you can make more money. And how nurses really make their money is they work a lot of overtime. But you can be a coder, you can work in HIM and make six figures. Don't work on Monday through Friday.
Mm-hmm. That's true.
So, depending on what you go into and the level of education you have going into coding or transition into coding, you in fact get a pay increase.
So let's promote you. What's your YouTube channel?
The Coding Nerds.
Okay, so we're gonna have to go out here and check out the Coding Nurse, the YouTube channel, check out your videos. I have a question for you though regarding that. So I know here in our area, I think one of the ways that they're trying to overcome or combat the nursing shortage is they're offering nursing degrees or RNs for people who just have a bachelor's degree, not necessarily in nursing.
Yeah, they've been doing that for like over 10 years.
What are your thoughts on that? So
I think it's fine.
Are they teaching them, nursing? Because I know. So are they teaching them the all the things they need to know for nursing? I mean, because it's like a 16-month program, maybe something like that.
Right. Here's what it is.
Or are they teaching them like nursing management stuff, or is it actually like to work as a nurse?
No, it's to work as a nurse.
Okay.
And I don't have a problem with that because people told, like, nursing school is prepared. It teaches you to pass the board.
Okay.
You only really learn how to be a nurse once you get your license and you start working. You go through orientation and training. It's just like going to cosmetology school. It only prepares you to pass the board.
Okay.
But you have to invest in further education on your own after.
Okay. So do you think this is going to be a way to fill that gap, or?
Well, the reason why they even have it is because in nursing, there was a big push maybe about 10 years ago. They wanted to work in a hospital, you have to have a bachelor's degree. Like that is the minimum level of nursing in order for you to work in a hospital. And the hospitals that only hire registered nurses with a bachelor's degree, those are called magnet hospitals. And honestly, it was a shot in the foot to nursing because you have a lot of 2-year degree nurses and you have a lot of diploma hospital-based RNs. So those two levels of nurses can no longer work in a hospital.
Is that across the board, or is that just certain hospitals?
Yeah, well, in most places,
okay,
that have magnet status.
Okay,
that's a requirement. You have to have a bachelor's.
Okay.
And that's really kind of what has exacerbated the shortage during the pandemic.
That's interesting.
Yeah.
And then you have people that are also on the other opposite end of the spectrum where they're retiring or burnt out and ready to go. And so wow. crazy.
It's just the workplace is just I don't know how it got so topsy-turvy, but it really is. And it's a combination of, in my opinion, gatekeeping, poor planning, and just lack of being able to think, being future forward.
Mm.
Like not really seeing trends, not really, because nurses really did not embrace technology until they really had to.
With the EMRs.
Yes, because after plenty of time, I used to hear older nurses say, "Oh, these computers aren't going to last. They're going to go back to paper."
Right, because they had them everywhere. I remember seeing them on wheels. You know, they weren't like in every room or whatever, but they would have the opportunity to do charting and do those kinds of things in the hospital before the true EMRs hit.
Right, but those were only in certain places.
Right. Wow.
And truth be told, like charting, well, those EMR systems were not really designed, they were designed with very little input, if any, from nursing and other departments, because there are things because they make it easy for providers, because I guess that's their main draw. They want them to be able to document, easily and quickly.
Right. Those are who they were marketing and targeting those systems for. So they're not intuitive for other people. I mean, even thinking about like, well, where do you find XYZ? Well, why would it be there? Because it's not intuitive to your thought processes.
Exactly.
Wow. So how are you coming along with your ebook?
I have gotten my outline together, and I was really just this past week, I was trying to think like, do I want to do a course at the same time as the ebook, or do I want to do the course and then launch the ebook as a companion? Because the more I think about it and the more I'm talking to people, I think that an ebook will be helpful, but I think some of them need like hands-on. I need to see it, like through like a course.
Well, I've seen people who've done courses and have their ebook as part of their course. So
that's what I was thinking.
Yeah, so your ebook, because you do have those who learn. You got to think about the different ways people learn, and so you do have people who actually just give me the stuff, let me read it, let me go through it. I can digest it that way. But then you also, like to your point, have those people who they need to see the diagram, they need to see, the visuals. And then you also have those who need like the hands-on. I need to just get my hands in here and do the work.
Right.
But yeah, I've seen people where it's kind of they play with each other. So you have your course and then you have the ebook as part of the course, and you go through kind of the course is the ebook, if you will.
Right. Because what I was finding was, especially for this clear lab and this mobile lab testing, honestly, Clary, there's so much information on the CMS website, and you can find all the codes, you can find the price list, but it's not all in one place.
No, you have to go through different. Yep.
Right, and if you don't know, then you don't know how to do a search, and you don't know how to find it, so it would just be cumbersome for some people. But the only thing that it doesn't really cover is it doesn't really cover modifiers. Because, like, for instance, the nurse practitioner, like she was saying that there are some people, when she does testing by her being a nurse practitioner, if they have a possible exposure and they have symptoms, she'll do a sick visit,
Mm-hmm.
and then she'll do like a rapid test, and then she'll do a PCR test.
Mm-hmm.
So I said to her, I said, well, if you're doing a sick visit and then you're doing testing on the same day, I said, then what you have to do is your E&M code, you have to append the modifier 25. Then your first test, if you're going to do a rapid test first, then that would just be the CPT code with the QW.
Right.
I said, but then if you go and do a PCR test, then for that test, you would have to have the CPT code, the modifier QW, and then the modifier 59. And, you know, she had no clue.
Interesting.
Yeah, because I was telling her, you know, the reason why you have the modifier 59 is because they're not going to know how you did it or why you did it. You're only going to get paid for one test. They're going to think that you just used that one sample for two tests. But you have to let them know that you did two separate tests.
That's interesting. So what do they look for as far as the documentation for those?
I told her, because he uses Carrier. So I told her, I said, you just have to put in your notes what you did, like in your plan, what you did and why. And I told her, I said, and if you're going to do a sick visit, I said, you know, now with the guidelines, I said, it just says a medically appropriate history and exam. That's because they're really basing it on medical decision making for a time. I said, but I would still include, you know, as detailed as possible HPI and just a basic exam. Like you would just do like the two system exam, like respiratory and cardiac or something.
Right.
You know, but just make sure you document it.
Right. Right. Yeah, you are absolutely correct. Your CMS website is a gem. There are all kinds of information and tidbits depending on, you know, the type of work you do, the type of practice you have or operating in, hospital systems, physician offices, surgical centers, you name it, you can find all the information. I mean, they literally tell you, because when they come back for you in audits, you know, it's like, well, the information was there. And again,
that's right.
You need to know. And if you don't know, then that's on you. That's a problem for you. So they provide that information. Always
what
provide
I found interesting was when I was looking around for these procedure codes for these tests. Like when for she also does monoclonal antibody treatment. And that's by IV infusion. So at first in my mind, I was like, well, I'm thinking, well, you have to use the CPT code that says, you know, that it is a therapeutic infusion for up to 1 hour. And then you would just need the HIPFIX code for the drug.
Right.
But they have their own code for the infusion. Because, you know, normally it's like 993 something, whether it's like an IM, whether it's IV, but they have their own CPT code.
Right. Oh, that was.
Oh, go ahead.
No. Finish your thought.
And then they have the actual HIPFIX code for the drug. And then they also even have the NDC number for you to put on the claim.
That was so the thing I was about to bring up, I remember seeing something about ICD 11. and there were questions about ICD-11 and, oh my God, are we going to be ready? And I know for the World Health Organization, they're releasing it in January, but of course, we would use the CM portion in the United States, and then other countries would use the various versions that are applicable to them. And the one thing that folks need to understand, and I don't know who taught folks this, because for some reason, I guess because we had ICD-9 forever and ever and ever, but they think, oh, I need to memorize these codes. No, it's like, you don't need to memorize the codes. You just need to know how to find the codes. And if you're working in certain areas, yeah, there may be some that you may memorize like the categories and you'll know, okay, well, this is that category of code, but not necessarily memorize a specific code to go with every circumstance, because again, every circumstance is different and the documentation that's listed may be different. So again, your guidelines are what helps you determine what the accurate code is, and it's not about memorization. And so it was like this whole thread that I was reading, and I was like, oh my God, who taught them that they needed to memorize? I was like, do you know how big this book is? Who's doing that?
Have you seen the I-11 code set?
Yes, there's a list of it out. If you go, I think it's at the if you go out to the WHI or the World Health Organization site, you can see the actual list. And it's I think the whole computerized list, because they wanted more of like, it's listed like a database to help foster kind of the ease with the EMRs. So it's going to be interesting to see what the twist will be for the CM part. And hopefully it won't take 11 years for them to get to get to ICD-11. But it's going to be a minute. I mean, it's not going to be within the next year or two. I don't believe that at all. No. Because again, we use it for so many different reasons, and making sure the necessary adjustments are made for those various reasons in one manual is going to have to happen. So it'll be interesting. It'll be interesting.
Now, what I found interesting was how they were saying that ICD-11 is going to have more codes than ICD-10. And they were saying that because the way it's set up, it's really set up like an encoder.
Mm-hmm.
So I'm like, there's no way in the world this code set is going to be entirely web-based, because they have whole publishing companies that will be put out of business.
Well, it's money in the books.
Exactly.
It's money in the books.
I don't see them letting that go that easy.
Well, it makes it. No, I mean, these books, and actually these books are they're not as big as the books that we used to have to lug around years ago when I started. That ICD-9 book way back a few years ago was bananas. And I remember the one book we used to use, it used to be a daily chore. Like it was a 3-ring binder type of situation. And so you wouldn't get a brand new book. You would get pages that you would have to add into that yeah, I'm dating myself. I know that you would have to add into that 3-ring binder. And that's how your updates happen, because it's gonna be updated every year. I'll back that up. It's gonna be updated every 2 years or twice a year. That's what they're going to, twice a year updates. So you'll have things updated in April, and you'll have things updated for October. Yep. They just released that a couple months ago.
Okay.
Yep. So that's more things that you'll have to find. So I don't know, like, in that instance, I can see the benefit of being kind of web-based because that's where you can easily get the information. But publishers, I don't see them flipping those books like that on a dime. I don't know. I mean, maybe they will. I don't know.
Well, I do get that, but here's my question. When you go to a web-based system and you do auditing, are you going to be able to reset the code set back to a year?
So they list, so there's I just looked at there's a ICD, well, it's an ICD-9 web-based tool out there. The CDC, I believe the CDC in conjunction with somebody, I can't think of it off the top of my head. I want to say it's the NC, I can't think, I don't want to butcher the initials, but anyway, they have it where they have the various years. Hi, Danette, welcome. Feel free to come up to the stage. They have it where you can go back. So you can go back to the code set that's applicable for the year that you're looking at. And so they keep that stored on the server, I guess. But right now it's only, I think it goes back to 17.
Really?
Because
I know, like in 2019, I had this contract position part-time where they did audits for 2016, and they were like a Medicaid contract, so we had to log into the CMS website, and they had a 3M encoder, but we had to look up the code in our 2016 code book and then put it into the encoder. Because the encoder could be reset to go back to 2016. Because, the guidelines are different.
The guidelines are different. Exactly. And well, it's always been my practice. I hold on to my code books for 5 years.
Right.
Just because of that. And then, if folks are, because even with audits, they can go back at least 10 years, 7 to 10 years.
Right.
And they can't audit you on what's new. If they're auditing you on something that's old, then you would need to have all of those materials and guidelines and all of those things to support why you did what you did. And you did what you did was basically due to what the guidance said in that year and not in the current year.
Right. Because now it makes sense. But if they move to a totally web-based code set for ICD-11, how are they going to be able to go back to ICD 5 years after they implement it?
Well, just like they go back to ICD-9, they still have things that they walk back to ICD-9 because for whatever reason, there's something going on with still ICD-9, and so that stuff still lives and breathes and exists as well.
No, I get that, but I'm talking about like just for revision, like because right now, like we've had the ICD-10. ICD-10. For 5 years. So that's fine if you have a code book. But if they're no longer going to publish books, let's just say they implement in 2026. In 2029, how are you going to go back to 2026 guidelines?
So again, on this web-based tool that I saw, everything is listed there. So you have all of the for that particular year. So it goes back to like 2017. And so it has not only the code set, but it also have the guidelines for that year too. So everything is sitting there.
Good.
Yeah.
But that was my only concern.
No, everything is sitting there. And again, it's just for the diagnosis codes. So I wonder what they're going to do with the procedure piece. And how is that going to work?
They'll change PCS.
I'm sorry.
I said, I'm sure they'll change PCS.
Yeah.
Follow suit, but those, CPT, those doctors, God bless them.
Well, they do massive changes and overhauls every year as well. Because they're always lobbying for, innovation and new technologies and new procedures that they're doing. So like they could have been doing a procedure that technically doesn't have a code and it defaults to an unlisted code, and they're continuing to show and show, the reason why a code should be developed. And so they lobby with their specialty organization to the AMA to say, hey, we have some research, we have some documentation, we have all of these things, give us a code. And then sometimes they give them like a temporary code, where they'll place it out there for like you may be using it, but are your peers also using it, or are they interested in that? So they'll sit a code out there it's usually out there for 5 years. If they see that it's a great need, then they'll bump it into the regular code set. And so that's how they kind of do their trial on codes. But then which was brand new, I had never seen anything like this before in my life, when all the things that happened with COVID, those codes were flying off the shelf. It felt like every month there was something new. It's like, oh my God.
Right. Now, I get that. I mean, I get the new code implementation, but I mean like a code structure change. Because like ICD 11 is going to have 4 characters in front of the decimal point as opposed to 3.
Right.
So with the CPT, I don't see the code structure fundamentally changing.
I don't either, because again, they have the catch-all unlisted code in most cases. And then you have the way that they can usually change it, with you have the parent code and the child code. And so they can make changes within the child code for that. So just like ICD 9 went to ICD 10, CPT wasn't affected by that. I don't think they would be impacted by this either.
Probably not. Well, in that case, I guess they wouldn't need to change PCS. Because that's different. Although I love PCS way better than CPT.
I know you mentioned that the other day.
I do. I love the whole root operation situation.
Well, and that's the key. And so with people who are learning PCS, it's that really you have to understand what those the definitions of those root operations to be successful in that.
But the whole answer is flashcards. That's how I learned.
Yeah. Yep.
And it didn't happen until I got to flashcards because I struggled. I'm like, why am I not getting this?
Because you're interpreting, you're putting your spin on it. You're putting your own personal interpretation on what you think it is versus this. They're telling you what it is. Just follow what they say.
Right.
Don't try to make it something else. Just follow what they say.
Exactly. When I put those laminated flashcards from Living Education, it was a game changer.
Yes. I love one of the ladies, well, the author of the CPT book, and she does their CPT, a lot of their CPT updates. She was my professor back in the day, so I love seeing her.
Okay.
Yeah. Be like, look at her, do your thing. She was great. So like, she's still out here educating the masses. Educating the masses. It's like there's hope for us all.
Absolutely. And that's the beauty of the HIM industry.
Mm-hmm.
Like there's always a need to stay relevant.
Yes.
And there's always something to learn.
Yes.
Because, like, for instance, can I tell you, I just recently learned that I was coding exacerbation of COPD and emphysema wrong.
Really?
Clarice, I sure was. I would do J44.1 and J43.9. but that's wrong.
Now, how did you learn that? How did you pick that up?
Because I read something and they referenced the coding clinic. But listen, I've been doing it wrong since 2017 because that's when the coding clinic was.
Oh, God.
What?
And that's the thing. So you have to stay abreast of not only the guidelines that come out with your book, but those updates, the coding clinics, CPT assistants, all of that. Because that's where they're putting the changes, or when to reinforce the intention behind some of the codes or the intention behind some of the guidelines, that's where they put that information. And so again, to me, it's back as a production coder, you don't have time to go through all of that. So somebody, management, somebody, I guess us, can help kind of focus or guide people into what the latest guidance is, or what the guidance is related to those situations.
But here's the thing, like Therese, like in 2017 up to 2018, I was I had to meet productivity guidelines and accuracy guidelines, and I'm sure I had to have COPD, but it never got picked up in an audit.
Oh, wow.
So I guess they didn't know either, possibly.
Possibly.
I'm like, oh my goodness. I had to write it down. I'm like, I ain't gonna make that happen again. Make that same mistake twice.
Oh my goodness.
Because I get it. I understood. Regular COPD and emphysema is J449. I got that. And you can even find that in the book. But you can't go to exacerbation of emphysema in the book.
What's up?
I haven't found.
Hello, welcome. I think we got a couple people to the room. I need to let you know that we're actually recording, so we're also on Zoom. So just be mindful of that as well. But welcome to the room.
No, thank you. What's a medical coder?
Oh, we got a virgin to the mic. Oh. So a medical coder is a person that takes documented information, diagnoses, as well as procedures, and assign them to a specific code for statistical purposes, for public health reasons, and for reimbursement. So when you hear about the numbers of people who have been diagnosed, and I'll use the most relevant thing with the COVID-19, they're getting that information from the diagnosis codes that are documented in the various patients' charts.
Oh, yeah, that's cool. Anyways, I'm out. I was just like scrolling around.
No problem. Well, thanks for popping in. All righty. Hey, Danette, am I saying your name right? I hope I am.
Yeah, you are.
Okay. How are you?
I'm doing well. I have to come back to last Tuesday and have me just write down so many notes.
Well, good. I'm glad we were able to help and assist. And if you have any specific questions, don't hesitate. Feel free to ask. And then don't forget to
add on to what you guys were just talking about. I'm a physical medicine and rehabilitation coder.
Okay.
And they kind of like took up my department because they just like changed how you code low back pain. Like now 5 codes to describe it.
Wow. Yeah. That was updated just for October 1, right?
Yeah, exactly.
Mm-hmm. Yeah.
And it's called our charge master, everything.
And that's a very popular diagnosis. So
Exactly.
Not just in your field, that's a very popular diagnosis. So yeah. I can see that bottleneck happening.
Clarice, I can hear you clear, but I have a lot of reverb when the net's speaking. I can't even make out what she's saying.
Uh-oh.
Is this better?
Say it again.
Can you hear me clear now, Jesse?
No, I can hear you, but it's just a lot of reverb. So with the reverb, it blocks out what you're saying. It's not clear.
Oh, I got her. I can hear.
And I get a feedback when I hear Jesse.
So it's me.
Maybe it's
Because I hear y'all fine. I'm sorry. I'm trying to do some things where we have the Zoom room and put it. Yeah, it's me. I'm sorry. It's me. But Jessie, she was talking about the coding changes that occurred in October for low back pain.
Oh, okay.
Yeah. Cool. Yeah. So has any of you, I see you have that, Jesse, you run into any things with the new code changes of yet?
Not really. The only, like when I had the home health position briefly, I think what did change? Was it fever? What is that now specified?
Mm-hmm.
Or the code change?
Mm-hmm.
I had to code that.
Okay. Yeah. So are you going to try the home health thing again, just not through them?
Well, it depends. If I get this CDI position.
Oh, it's a wrap. You'll be in heaven then. You'll be well on your way to be the CDI expert. Huh?
That's the plan.
All right. Love it.
Especially if they'll listen.
That's what's up. I love it. Well, don't forget about us little people.
Definitely not. What I'm also planning, what I really want to do, because Clarice, I told you before, Jeanette, I shared this. I think the whole CDI exam by a human is some bullcrap. Like, I don't know where they got that exam from, but it was not in any of their study materials. So right now they have you can get your HEMA approved CDI trainer designation. So
oh, really?
I'm thinking about getting that. And then training people properly.
Yeah. Well, just like we talked about the coding training, because they have specific domains. Don't they have specific domains for the CDI as well?
They do, but I don't know where those questions come from.
Oh no, I was thinking about looking into that certification for CDI.
Now, the thing I really do like. AAT, then you have to specify whether it's inpatient or outpatient. Then if you do CCPS, you have to specify whether it's inpatient or outpatient. Me personally, I will tell anybody to either be certified through ACDIS or a HEMA. But ACDIS, they have stricter requirements for eligibility than a HEMA. Okay. So that's why I want to get my CDI trainer designation. Then I could train people to pass that test. I know people who've taken it twice and failed.
Because I think ACDIS, they're the ones that offer like the boot camps where you can go like to Florida for a weekend.
Oh, really?
Yeah, I was on their website and like they have it where you can do a week or a virtual week or like a week scan, and they have like designated places that you can go, and like you can get a package with the hotel.
That sounds expensive, is it?
She just laughed.
It's a goal, not a plan.
Wow. Wow. Well, glad they offer that. And again, that's so if you see they're going to still need certified coders because certified coders are going to branch off into other areas. And move, and so it's like a circle of life. It's never an ending revolving door.
Definitely.
Yeah. So the people were. Go ahead, Danae.
Oh, go ahead.
Danae, you were going to say something?
Oh no.
Oh, I'm sorry. Go ahead, Jesse.
And just like I was saying last week, I really do think that they need to make a requirement that these CDI people know coding. They should be coders.
That's true.
Yeah. Yeah. Because that's the one thing, you know, it reminds me of quality all over again. I'm dating myself. It reminds me of all the quality stuff that was going on back in the day. You know, coders, the HIM profession and nurses were competing for these quality positions because they felt like nurses, I don't know, the coders couldn't do it or whatever, and nurses were better suited for it. And I think we're living that same example here with CDI.
Exactly. That's a perfect example.
Mm-hmm.
That is a perfect example because I've noticed a position opening up in my organization, and a lot of them requiring you to have a background, and only for CDI outpatients are they allowing coders to do those roles.
Wow. It's gonna be crazy. See how this all falls out. Like, really? Like, really? When you gonna learn? We know how to do it all.
Exactly.
We know how we've been trained for it all, and we can pivot on a dime. So when you gonna learn? And you need your nurses in other areas. But no, I understand their burnout and wanting to come over and learn. But understand that you don't have you can't capitalize or monopolize in this area. It's no. There are some things that you need to know, and some things we all need to know, and we should be able to work together to make to the greater good of what we're trying to do.
I totally agree, and I think that if you're going to make the switch, you got to go up the ranks like all the other coders.
Yeah.
You get a core credential, then you get a specialization.
Yep. Yep.
Because that even happens like, I'm an LPN. There are some coder positions that will not hire me because I'm not an RN.
Really?
Now, yes. Now, what I'm trying to understand is, truth be told, the only difference in the role of an RN and an LPN is clinical. When you are on the other side and you're in auditing or CDI or whatever, it is all based off of documentation. So it's no longer clinical. So why should it matter?
Right.
But it does.
That's interesting. Interesting. I didn't know that. I didn't know they restrict LPNs. I would think, you know, you have a nursing clinical to a degree background. Why would that hinder you from those positions? That's interesting.
Did I tell you the story that happened? This was last year. Here in Philadelphia, one of the insurance companies, a recruiter contacted me. The company wanted a certified risk adjustment coder who was a nurse.
Mm-hmm.
That's all they said was a nurse. I submitted my information to the recruiter.
Mm-hmm.
The recruiter called me a couple days later and said, well, they only wanted RN. So I said, okay, I moved on. She called me back about a week or so later,
Mm-hmm.
saying that and was the nurse, it was $38 an hour. So then she called me back and said that they changed the position and it's no longer, you don't have to be a nurse any longer. And they lowered the pay to $33. I'm like, well, this risk adjustment shouldn't be too bad. Okay, I said, okay, you can resubmit. So time goes by, they contact me to schedule an interview. The day before the interview, the recruiter calls me and asks me for my license number and a copy of my certificate. I said, why? So she said, the employer wants to see it. I said, well, you told me that they no longer required a nurse. I said, so if they want to verify my license and they want to see a copy, they got to pay me $38 an hour.
So what?
I canceled the interview.
So what was the? I'm like you, like don't capitalize on what I bring to the table and not compensate me for it.
Because that's what it was all about.
Wow. Wow. Wow.
And then, so when I canceled the interview, of course, now she kicked the can up the road. So now the big boss called. And he tried to sell me the open door. I said, listen, sir. When it comes to money, I don't play. Now you're trying to sell it to me, and you know you would do it. These people clearly said that you had to be a nurse. Then they said you don't have to be a nurse. If you want to verify my nursing license, you have to pay. Period. Mm-hmm. So so the position falls by the wayside. I get contacted a month later through another recruiter for the same position.
Wow.
Crazy.
And they got the right one, huh?
Well, Jesse, I did learn from you last weekend because you were saying you had mentioned something about if you're working denial, that's basically auditing, and if that's not in your job, they should be giving you the compensation for that. And so I have brought that up to my supervisor, 30% of my pay, I'm working denials for work that I didn't do. And I kind of feel like I need to, be compensated for the work I'm doing as an auditor. And so she said, that's very true. So just make sure you mention that in the next interview.
That's right.
Wow.
Get your money.
That's true. That's true. And
I really appreciate that, Mr. Jesse.
What'd you say?
I really appreciate that knowledge you gave me.
Oh, thank you. I'm glad to help.
well, he's the negotiating king over here. When it comes to the dollar, he goes, no, ma'am, and no, sir. Like exactly, spell out exactly what it is you want me to do. Oh no, this is this costs this costs this, and this costs this.
Make sure you know your word.
Exactly. And that's the key.
But you know who told me that? Nurses. When I tell you nurses don't play about their money, they will leave jobs for $1 an hour more.
Wow. Well, they have these traveling nurses that they said are just doing it up, and they're walking away from these positions as what these regular in-house positions to be traveling nurses.
They are.
And the money that they're making as a traveling nurse, oh my God. I know a lady, she only works 2 months out of the year.
Wow.
Oh,
One of my coworkers, one of my former coworkers, she's an RN and a coder. She was in Alaska.
wow.
Her 6-month contract in Alaska was going to pay her $180,000,
Wow.
but she had to come back because her husband got COVID.
Oh.
I just seen a job posting on Indeed for traveling nurses in Alaska, and it like really made me stop and say, really?
So why do they need so many nurses in Alaska?
Because COVID is through the roof in Alaska.
Oh, they're now one of those higher areas of oh.
And it's so big.
And vast, yeah. Wow. Never wanted to go to Alaska. Only to visit on a cruise ship. I've seen pictures and it seems pretty, so that would be the only reason why I would be in Alaska.
Yeah, I have family stationed there, and he sent me a picture of a moose that was in their neighborhood. And when I seen that a moose is taller than a house, I was like, yeah, I won't be in Alaska.
No.
Exactly.
They doing the most over there. Doing the most. With the moose. Oh well. No. Oh, cool. Oh well, look at the time, y'all. It's 10:38. I know, Jesse, you got several other rooms to hit this morning.
Actually, I might do one more, then I gotta clean.
Okay. Yeah, this is the Saturday morning check-in. We find out what's going on in our industry.
Definitely.
Find out what's happening. Well, thank you all for joining us today with our Saturday morning tea. It's been fun. As usual, we've run the gamut and talked all things medical coding, health information, entrepreneurship, nursing, and those transitions. Our co-host here, Mr. Jesse, the coding nurse. Feel free to check him out on YouTube. Don't forget to check out our 5 steps to become a certified marketable medical coder. If you're interested in medical coding or want to get a better understanding of what it takes to be in our world, it's like a free little course for you to dive into. And don't forget to connect with each other. You know, resources is everything, and networking is everything. And who you know and what you know combined helps you get to where it is that you're trying to be. So again, thank you all for joining. Hit the green Clubhouse to be notified. I feel like I have a whole PSA, don't I? Hit the green Clubhouse to be notified when we come back every Saturday at 9 a.m. I hope you have a wonderful weekend, and I talk to you all soon. All right. Bye-bye.
Good day, everybody.
You too.